I'm Denise Fisco, and I'd like to welcome everyone to another users meeting. And for our section, we're going to talk about treating astigmatism, taking that to the next level with LENSAR and Ally in the future. So as an introduction, we all are very familiar that residual astigmatism has a measurable impact on a patient's visual performance after surgery. We know that addressing the astigmatism at the time of the surgery influences the patient's perception of whether their surgery was a success or not. And the old hat way of thinking has been a half a diopter or more will treat, half a diopter or less was well tolerated. But astigmatism as low as a quarter diopter is treated in refractive surgery, such as laser vision correction. And that quarter diopter has the potential to affect the function and low contrast acuity, and also the patient's satisfaction. So targeting corrections as low as a quarter diopter, I think is appropriate. 63% of patients have astigmatism less than 1 1/4 diopters. 1 1/4 diopter is about the level where most people start to look at a toric lens, sometimes a diopter if it's against the rule. But we know for those low levels of astigmatism, astigmatic incisions are the preferred procedure. And interestingly, the femtosecond laser-assisted AIs that are made perpendicular to the corneal plane are similar to the AIs that we create manually. And this is not the astigmatic incision that we create with the LENSAR. What we're creating with the LENSAR is perpendicular to the corneal plane, so it behaves as a beveled incision. These incisions are less likely to be associated with regression. And so here's a schematic showing that, where we can see on the left the figure showing the gaping of the corneal incision that is created, similar to when you would do it with a knife. And these incisions potentially are more prone to gaping and epithelial plugs. And then we can see the beveled incision that the LENSAR performs, which allows the anterior cornea to slide forward in relation to the posterior cornea so that it realigns the stroma. The healing occurs without wound gaping, and so we have a more stable result. And the proof is in the pudding. So these are the results that I published in JCRS, 263 patients. The range of astigmatism was above a half a diopter for these patients, and we can see that the results were stable at 1 year, and they were just as stable at 1 year as they were at 2 weeks. There was no statistically significant difference between that time period. And then we can go into the low astigmatism. These are patients that had preoperative corneal astigmatism that was 0.6 diopters or less. Many of these patients were my multifocal IOL patients. So you have 0.3 diopters of astigmatism in a multifocal patient, you're going to go after that because it can affect their satisfaction with that particular product. And we can see that 96% of eyes here achieved less than or equal to a quarter diopter of residual refractive cylinder. So in conclusion, we're going to have different presentations from our panelists here talking about astigmatism correction, specifically with Arcuate incisions, which is kind of what I've been known for a bit. I have 3 pertinent pearls. The first one I didn't even mention yet, and my entire talk is that everything has to be perfect before you go in, right? We have to have perfect corneal topography measurements. We have to be completely confident that we're treating a beautiful ocular surface and that our measurements are accurate. And then we want to pick a nomogram, do the same thing every time in your surgery. And then finally, when you're developing that nomogram, you want to retrospectively go back, look at every 50 eyes to see how your performance is. You can adjust that nomogram very easily in the LENSAR system. Your clinical apps person can show you how to do that. It's not a matter, it's very sophisticated. You go in on the graft and you move the line up or down based on what your results were for a particular refractive range.
I'll be speaking about early results of a comparison study that is still going on, and the study is about comparison of the AKs created with LENSAR versus the Catalyst femto laser system. Next slide. So I'm sure we all agree with this, that the femto laser-enabled Arcuate keratotomies are more effective and safer than manual LRIs, and this has already been shown in various publications. Next slide. However, all femto lasers are not the same, and they can have variable results due to differences in the nomograms used, and also whether the laser is able to do an iris registration and compensate for the cyclotorsional error or not. So various lasers have already been evaluated and the results have been published. However, to the best of our knowledge, there is no comparison study that compares to different femto laser platforms in terms of the safety and efficacy of Arcuate keratotomy reported so far. So this brings me to the purpose of my study, next slide, which is to compare the 6 months outcomes for safety, efficacy, and predictability of LENSAR Femtosecond laser system versus the Catalyst precision laser system from J&J Vision. So we intend to recruit 50 eyes in each group. However, at present we have 25 eyes in the LENSAR group, which have been compared retrospectively with 25 eyes which were treated with Catalyst laser. We included patients within the age range of 50 to 80 years. They had healthy eyes besides cataract. The range of preoperative astigmatism in the study was 0.75 to up to 2 diopters, and the intended follow-up is 1 year, 1 month and 6 months. So today I'll be presenting 1 month comparison data for this study. So this is basically the methodology in the LENSAR group. So we have the Pentacam HR, which is remotely connected with our LENSAR femtolaser system. With the Pentacam, we capture the preoperative iris image first, and we also capture the keratometry data, which is on the day of surgery wirelessly imported into the laser in the operating room. This is essential for the iris registration and cyclotorsion compensation. So this is a brief video showing the workflow of LENSAR in our system. So we already have the patients whose Pentacam has been done. So we import the patient who is posted for the surgery. The patient comes under the profile of the operating surgeon, and then various other parameters such as the fragmentation, capsulotomy, incisions are planned. So the eye is then docked, and in this particular eye you can see very well that there is a cyclotorsion of 10.5 degrees. Now this is so important to compensate this cyclotorsion, because if this is not done, there is going to be a 30% undercorrection of the astigmatic correction that is achieved with the LRIs, with the Arcuate incisions. So this is very important. The laser has done a good cyclotorsion compensation. And now let's also look at the workflow in the other group. Next slide. So the AK planning in the LENSAR is automatic. There is an inbuilt nomogram. Already the previous speaker has spoken about it. So we get at 8 millimeter zone, 90% depth. And this nomogram, the Nichaman Woodcock nomogram, accounts for the posterior corneal astigmatism also. Whereas in the Catalyst group, the AK planning was manual, completely manual. So we have to go to the LRIcalculator.com website. It uses the Donenfeld nomogram, and for the AKs at 8 millimeters, we need to reduce the arc length by 20%. The incisions are given at 80%, and it does not account for the posterior corneal astigmatism. So the LENSAR software also has many other advanced features using which you can further optimize your results. So such as it has the against the rule and with the rules tables, which allow for further optimization by increasing or decreasing the gains. It has the age modifier. It also has additional modifiers for white to white, central corneal thickness, rate of curvature, etc. And it also accounts for the surgically induced astigmatism. So if you use all these features, the results are going to be better, and you can further optimize the outcomes. Regarding the cyclotorsion compensation in the LENSAR group, it was automated using the preoperative image, whereas in the Catalyst it was manual, so you need to mark the eye in 0-180 degrees, and then the suction ring has 2 inner projections which need to be matched with the limbal marks. So, and then it has to be rotated, and then the laser has to be fired. Surgical procedure was identical in both the groups. AKs were opened always at the end of the surgery in both the groups. So preoperatively, all the parameters were matched in both the groups. Next slide. There was no statistical significant difference. At 1 month, if you can see, 1 month in the LENSAR group, there was a significant difference, a significant reduction in the corneal astigmatism from 1.2 diopters to 0.38 diopters, and significant flattening of the steep keratometry from 44.7 to 44.13. In the flat keratometry also, there was a significant steepening. Whereas in the catalyst group, you can see also there was a significant flattening in the steep keratometry, and that led to the corneal astigmatism reduction from 1.19 to 0.45, which was also statistically significant. At 1 month, the UDVA, CDVA, sphere, cylinder, and spherical equivalent was comparable in both the groups with no statistical difference. We also subjected the data to vector analysis, wherein you can see that the target-induced astigmatism and surgically induced astigmatism was matched. However, the correction index was statistically significantly different. So in the LENSAR group, the correction index was 1.04. In the catalyst, it was 0.97. So there was a slight overcorrection of about 4% in the LENSAR group and slight undercorrection in the catalyst group by 3%. This is the SIA versus TIA graph, where you can see that in the LENSAR group, there are few eyes, most of the eyes are on target, bang on, but there are 4 eyes which got overcorrected, whereas in the catalyst group, there were 5 eyes which got undercorrected. The difference vector was less in the LENSAR group. The difference was not statistically significant though. This is really important, and you can see that the angle of error within 15 degrees, the percentage of eyes in this range was 92%, which shows better placement of the incisions, more on target, whereas in the other group, this percentage was 84%. As regards the refractive astigmatism, 96% eyes were within 0.5. In the other group, it was 92%. The uncorrected distance visual acuity, 92% eyes in the LENSAR group were 20/20 or better versus 88% eyes in the catalyst group. Hence, at 1 month, we saw good correction and significant reduction of preoperative astigmatism in both the groups. LENSAR group showed a mild overcorrection by 4%. In the catalyst group, there was a mild undercorrection, which is probably expected to regress a little bit over the next 6 to 12 months, probably resulting in near perfect correction. In LENSAR, it's already perfect because 4% undercorrection is not too much. It was not clinically significant. So to conclude, both laser AKs were safe and effective in reducing preoperative astigmatism. The mild overcorrection in the LENSAR group was not clinically significant, as 92%, that is 23 patients in the LENSAR group versus 22 patients in the catalyst group had excellent distance vision and did not need glasses, and they were very happy with their surgery. However, we await the 6 months outcomes of this study, and because we are studying corneal incisions, so long-term outcome is always more meaningful and interesting. So thank you so much for your kind attention.
I want to just targeting astigmatism correction to equal to or less than 1/4 versus 1/2 a diopter of residual astigmatism using toric IOLs aligned with femto laser capsular marks with LENSAR. So Denise already said this, 87% of patients present for cataract surgery have some kind of astigmatism, and 65% between 1/4 and 1 1/4, and 22% are greater than 1 1/2. So we know that if you don't correct astigmatism, that's the low-lying fruit. If we don't correct it, patients are going to be unhappy. If you miss your target, like Jonathan said, your spherical equivalent, if you're not on target, they're going to be unhappy because they've got to wear glasses. So what I wanted to show was if we correct our astigmatism lower than 1/2, is it going to improve patients' satisfaction? And everybody's, we'll just we target 3/4 of diopter of astigmatism and patients are going to be happy. Well, I'm not sure. There are consequences to pay. So let's just see what I did. So toric IOLs, like John said, with the new Invista toric correcting 0.9% of a cylinder at the corneal plane, that's allowed us to correct with a toric lens less than a diopter of astigmatism. So accurately aligning these toric IOLs, it's really important. The ways we've marked, conventionally the way we've marked corneas before with a bubble, a pendular markers, they bleed, it's just incorrect. It's just hard to do. Even at the slit lamp, it's hard to do. So LENSAR's IntelliAxis marking system is just awesome. It's a pair of marks or on the capsular rim, placed 180 degrees opposite one another. That's on their standard laser capsulotomy procedure. And these marks allow us to align the intended axis of astigmatism. It also takes care of the parallax error, and it also allows us at the slit lamp, the first postoperative day, to see whether our toric lenses are aligned. And if they're not, we know right away that they're not, and we can easily, if you rotate them at the slit lamp, to rotate them back. So the purpose of my study was to review some cases with different toric lenses to see what the results would be using femto IntelliAxis marks, and to see what the visual results would be at a quarter versus a half. So this was my study design. It was a retrospective chart review of 195 patients with pre-existing corneal astigmatism of greater than a quarter, corrected with either True Line, Panoptics, MX60 ETs, all toric IOLs. Patients underwent implantation of toric IOL guided by LENSAR IntelliAxis and confirmed with Aura. Group A, 105 patients' eyes had residual cylinder of 0 to a quarter, and 90. Group B had cylinder of a quarter to a half diopter. We measured the outcomes of mean preoperative astigmatism, residual cyl, uncorrected visual acuity, effects of residual cyl on the visual acuity. Next slide. So this was the results, with more than half of the eyes, at 53%, achieving a residual astigmatism of a quarter or less. Astigmatism reduction statistically significantly from preoperative to postoperative cylinder from a mean 1.14 versus 0.28 was statistically significant. And my range from post to pre was 93% were 2.5 to down to now postoperatively to 0% astigmatism at 36% and 100% diopter or less. And this is just showing the visual outcomes. 97% were 20/30 or better. And again, we're just talking about outcomes and the improvement of visual acuity. And this is just showing that we've got to correct the spherical equivalent so that we know that we can improve the cyl. If we don't correct the spherical equivalent, we're not going to improve. It doesn't matter what we do with the cyl. They'll still have to wear glasses. So in conclusion, leaving low levels of astigmatism untreated can negatively affect the uncorrected distance visual acuity. And the present study showed that this improved 2.5 ETDRS letters if you corrected 0.25 diopters of astigmatism. And the technology advances with the improvement of addressing the lower amounts of astigmatism with the lenses, and the precision of this and the safety of it is really important. Denise showed 80% as in 2019 in her JCRS article, 68% with Gary, and these were AIs. So mine with toric shows 53%. So this is a great way to lower corneal astigmatism and improve patients' outcomes. And I think that we all need to look at limiting our astigmatism to a whole lot less than 3/4 of a diopter. Thank you.